So palliative care seems to be the black box right now in healthcare. And I think it's a lack of good direction, a lack of good definition. What's palliative care? What's end-of-life care? When does it begin? And who's responsible for it? So I think that when we talk about palliative care, we're going to need to get a lot more definition to really understand it the way we need to understand it.
Yeah, I mean, to your point, if you look at the NCCN guide, the formal NCCN guideline for it, it is a flow chart that is very nonspecific. It's very complex, and I don't think it really is fully addressing the issues. I mean, my read of the guideline is very complicated with a lot of subjective things, and really doesn't approach. To your point, I don't think they're well crystallized at this point.
And on the basis of having those guidelines out there, we haven't seen any improvements in the quality of palliative care in this country. Despite Temmel's article back in 2010 showing that in lung cancer, patients actually live longer with earlier palliative care, what we see from Morden's data in Health Affairs and updated in Dartmouth Atlas is that we still have about only 50% of cancer patients getting into hospice. Average length of stay is about a week. And worse is that more are ending up in ICU than ever before in the last month of life. And there's an increasing percentage of patients getting into hospice for 3 days or less.
Well, I think another issue is in both the ASCO guidelines and the NCCN guidelines is they recommend initiating discussion once the patient clearly has advanced disease or once the patient is having intractable symptoms and as the initiation of it. I think, frankly, probably palliative care discussion should happen much earlier in the treatment of patients. It should probably even happen as part of the care in a primary care setting before anybody has a disease. So I think that's one thing that I noticed that the pathways seem to promote is just waiting.
This may be one of the most difficult hurdles to overcome because the different stakeholders have different opinions. You ask a palliative care physician, they think with the diagnosis there should be that discussion. And they see themselves as having a role in the continuum of care for symptom management. You ask the oncologist thinks, that's what I do is symptom management. That's part of my training and part of my scope of my work. And I don't think patients coming to me newly diagnosed want to have that conversation. You ask patients, you get a different story. So if trying to figure out what is the right time for the patient, and is it likely disease specific, it may be different for breast cancer than lung than colon, is going to become a really important discussion that needs to take place. So I'm working on a pilot in my work with Pathways where we're asking the physicians who make up the steering committee, and I think this could be interesting and something to discuss with some of your programs like you're doing in Miami, but we're asking the physicians, when do they believe it's the right time to start that conversation? And what we've been hearing from the doctors we're working with is when they're ordering the last line of treatment that has survival benefit evidence. So that's kind of an interesting concept. So it wouldn't be first-line metastatic breast cancer, but it could be third or fourth-line metastatic breast. You know, from your comments, that might not, you not think that's too late, but these are still generally patients who are walking, talking, coming to the office, outpatient therapy, not hospitalized. But it's not just the same. Lung cancer, second line of therapy, colon cancer, third line of therapy. So what they want to be able to do is say, you know, we still have something else to try that evidence says may help you live longer, but I also recognize if that doesn't work, there's a lot to discuss.
You know, I think that, you know, that approach, I understand why physicians will want to do that, but then you have this absolute transition that seems to occur. Okay, you're sick, and now you need to be palliated. So now we'll address more issues of your comfort, of your function, and how you're working. And maybe that's something that belongs earlier in the care. You know, not that you make a transition, well, okay, now it's no longer curative care, you can move to palliative care, but maybe palliation of symptoms, even though there may still be cure as an option, and involving the palliative care process earlier on, you know, I think may be more beneficial to some patients.
It's going to be interesting to see how this unfolds and what the caring physicians are willing to accept. I guess I'm looking at it, we may have to take baby steps. You know, if we can get first that 50% rate of referral to 70%, if we can get that average length of stay from 1 week to 2 weeks, that's moving the ball in the right direction. And I'm worried that if we ask for too much, we'll be stagnant and stay where we are like we've been for the last decade.